me, I am Lauren Sanina. I am a member of the Future Voices group. And just a little blurb about Future Voices. We are a student group committed to fostering a space for students to collectively create a more diverse, equitable, and inclusive College of Nursing. The organization accomplishes its mission by supporting DEI events, trainings, and initiatives across campus, creating open forums for students to discuss ideas and concerns surrounding our campus culture and curriculum. Furthermore, it connects with other campus groups to build a community in the name of creating a more diverse, equitable, and inclusive environment. And our guest speaker today is Dr. Cleveland Piggott. I recently met him while completing my clinical rotation with AF Williams Family Medicine. Our preceptor set up a call and introduced us so that we could discuss issues related to health equity and particularly as related to preventive and ambulatory care. Our conversation was very inspiring, so I reached out to ask if Dr. Piggott would be willing to present something for Future Voices. So, a little intro on Dr. Piggott. He is a family physician at the University of Colorado, Department of Family Medicine. As a faculty member, he co-founded the JusticeLeague, a working group on diversity, equity, and inclusion at Colorado's Department of Family Medicine, and is now the inaugural vice chair for diversity, equity, and inclusion for family medicine. Dr. Piggott has worked on DEI and anti-racism issues at the local, state, and national level, both inside and outside of organized medicine. In addition to DEI efforts, Dr. Piggott has a full panel of patients and teaches both at the medical school and residency program on various topics. And here's what we plan to do for today's event, and correct me if I'm wrong. Dr. Piggott will share his story and big picture of the work our groups are trying to do. Then he's going to hone in specifically talking about the clinic work. And then we'll have the rest of the hour for Q&A. So without further ado, thank you for being here, everyone, and take it away, Dr. Piggott.
So nice to be with you all today. I'd love to know a little bit more about who's in the room. So if you don't mind in the chat, just saying your role and why you're interested in health equity, and we'll come back to that. And you just hit the nail on the head where my goal is not to be talking at you all very long, 20 minutes, 30 if I become really long-winded and get really passionate about something. But then hopefully we just turn off the PowerPoints and just have a discussion, ask questions, engage on some really hard topics. And so I feel like everyone needs to have an objective slide, but I think the main thing here is to learn a little bit about my journey and the journey we've done in family medicine, but ultimately reflect on your own journeys and where you want to go and have a dialogue. And I want you to feel free to ask questions, speak up. It's hard for me to see the chat while I'm doing this, so if anything comes out, just feel free to speak your truth. And also, happy belated Nurses Week. You all are amazing. Oh my gosh, I love our nurses. Thank you, thank you, thank you, thank you. And that's all I'm going to say. But I really appreciate you, and you all do not get the appreciation that you deserve from lots of people, including my fellow physician colleagues. And so I'm sorry about that, but I wanted to at least tell you I appreciate you and thank you for all you do. And so who am I? So you all got my bio CV sort of talk, and I'm going to tell you a little bit more about just sort of me, I think, as a real human, because I think sometimes we can hide behind our degrees, hide behind our experiences and what we've done. So for me, my parents are both immigrants from Panama, and they came here like all immigrants. They want to have a better life for themselves and for their children. My mom has a big heart and is just really imparted that into me. My father imparted balance on me. And I remember growing up how he'd always say you have to work harder and do more just to be thought of as equal. And as a child, I had no idea what he was talking about. I was like, okay, I like school anyway, so that's fine. But as I went through my training, I realized that people that looked like me were not getting the same care. And everywhere I looked, there were so many inequities, both inside and outside the healthcare system. And it was really hard. And I did some internal work, and part of it was thinking about what is my own personal mission, vision sort of statement. And for me, it was pretty simple. It was do the right thing and make things better for people that come after me. And so as I was thinking about how to do that, I did that, of course, through my work in medicine and my love for science and people. But I distinctly remember a day where I was laying on the ground chanting, "Hands up, don't shoot," at the annual campus White Coats for Black Lives Die In. And what should have felt like a moment of solidarity with people from all different campuses all there, I realized that though I was part of a department full of like 200 people, I was the only one there. And I'm usually the only one in the room. Is that my colleagues didn't care? I didn't think that was true, and I tried not to tell myself that story because I would go down that a dark path if I did. But it did prompt me to engage in a conversation. So I talked with our leader of our department chair, and just had an honest discussion about my experiences and what I felt like our department was doing and not doing when it came to health equity. And he said, "You're right. We're failing our patients. We're failing our patients because of our lack of diversity. We're failing our patients because we're talking the talk, we're not walking the walk. But Cleveland, I've earnestly tried and failed." And so I asked him if I could try.
I think you just muted yourself.
Can you hear me now? Okay. So he asked me to try, and I said, "I'll do it." And so cue the Hamilton music in the background. I was like, this is my shot. Let's do this, but I can't do it alone. And so I found a colleague, a researcher who was arguably more passionate about this than me. And we came together and we created a group that we called the JusticeLeague. And so why the JusticeLeague? It's simple: a working group of diversity, equity, inclusion, anti-racism is way too long of a name. Plus, being the only Black male physician in my department, I could say that I was Black man, get a laugh, and then tell folks that they can't say that until they hire more Black people. So when thinking about diversity, equity, inclusion, when I was thinking about it from our department perspective, I looked at our department mission. It was a nice, simple mission: help people be healthier, right? Everyone can get around that. And when I think about the importance of diversity, equity, inclusion, it's pretty much helping to make sure that everyone's healthy and that we achieve our mission. If we don't have diversity, then we don't benefit from the creativity of diverse voices and people in the room, and we know we have worse patient outcomes. If we don't have inclusion, people just don't do their best work, and they eventually leave. And if we don't have equity, morale's just low. People don't feel like they're treated fairly, and we're not able to be successful. So how did we do this, right? Our department chair has been around since the dawn of time. He's finally going to retire. Wonderful man, but he's old and he's tired. So he's been trying to do this for a while and failing. How is I, brand new faculty without much resources, going to do this? And so first and foremost, we want to figure out who is interested in this work. So we did our call to action, our catchy name, formed a listserv. A lot of people raised their hand and they signed up. We want to evaluate where we were on these issues. It's really important to understand what systems are. We come in like guns a-blazing, like this should be better, blah, 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 you should do this. Everything's always more complicated. And so took that humility and realized things are bad. Let's figure out why they're bad. Let's figure out what might be a solution, what might not be a solution, who might be allies, who might be in the way. And so we did what we call like a SWOT analysis. So that's like a strategic planning, strengths, weaknesses, opportunities, and threats. And we made sure we had people from all over the department there involved, because we all had blind spots. But when we had people from different areas, people that had been there longer than I was born, people that were in research, people that were staff, people that were faculty, we were able to find out what most of those challenges would be. And so that was super helpful. We also wanted to educate ourselves first and foremost. So we took a lot of those people that signed up for the Justice League and let's learn about topics. Let's learn about topics we're passionate about. Let's learn about topics that other people care about, right? That really gets to their core. I am an able-bodied cisgender male. So I don't know much about disability because I haven't lived through that, but that doesn't give me an excuse to not. So I use my privilege to allow folks that were experts on that so we could learn from them and advocate for their voices. Same thing with other groups that I don't feel a part in. And then we also realized, you know who has the money? Leadership. I don't have money. No, I can't. And so we had to make sure that we were aligning with leadership's values and talking their language. And we also tried to help change those values a bit by focusing on things that were their North Star. So their mission statements, showing up to their meetings, trying to advocate for funding. We knew we wouldn't get it right away, but if we could show we do good work and we positioned ourselves well and made them like us and made ourselves essential, they would eventually fund it. And also keep in mind, an organization's values are very much related to their funding. And so oftentimes I don't ask to see, so I say, let me see your mission statement and then let me see your books. If I can see where they're putting money, I know what they care about, right? And then we wanted to hear people's voices. We had their voices for the SWOT analysis, but we also did a climate survey. We wanted to have data and stories. Part of it was to see what we're doing well, what are some things we need to do better, and then how can we amplify those voices so we can make a department and change where everyone felt welcome. And then build and form relationships. That's what we do really well in healthcare, nursing, family medicine. We hear people's stories and we build on them. And so that relational leadership. And we went and connected to conferences and met up with people that have been doing this longer than us and essentially just stole what they were doing and used their format to figure out how could we do it ourselves. No need to reinvent the wheel because we're all busy. And so we were excited. Things were getting started, but it's still hard. We saw some low-hanging fruit. We worked on a website, worked on mission statements, got some funding. That was exciting. We learned a lot about ourselves and our society, and we're able to use lots of resources that already existed. The climate survey also showed people actually cared about this stuff. And so we were able to then help use that to get different direction. And something that you all might be facing now, there's not a lot of people outwardly willing to say that they're against this sort of stuff. And so they're at least verbally saying, oh yeah, that's good. Whether they'll actually do anything about it is a completely different story, but that's a start, right? We also learned lots of people raised their hands, but few people would show up. It's just reality, we're all really busy. We were running out of low-hanging fruit after a while. We did a lot in the first year, but then the rest of the stuff took like dedication and we're all busy. You know, as you all are students and we're using things like residents and so forth, there's turnover there. It's just a lot. We need to prioritize things. And sometimes you're doing this in after hours, right? You're doing this during your lunchtime. You're doing this in the evening. You might have kids. All this sort of stuff has huge factors in whether the sustainability for folks to continue doing unpaid work. And we had to do things to change the culture. And so we started going to meetings where they already existed as opposed to making our own meetings. And so we weren't asking people to show up to us. We were showing up to them and just got ourselves in the books so that it would be part of who we were and not just what some people wanted to do. Then we also realized we didn't have enough champions at the leadership table. And so we'd have things that come out and we're like, what are they doing? And it would have been easy if they just would have had a diverse group of folks. For instance, our department will put out a big magazine each year in which they talk about big issues. And one year they put out a magazine in which they featured like 5 different people, and they were all white men above 50. You're like, seriously? You could accidentally do better than this. And so they had all this sort of stuff, and it would have been so easy if someone just been like, hey, and they would have been like, duh, but no one was at the table to stop them. The next time they had a whole issue where it was just all women. But it's just those little sort of things where we could help them figure things out. This work is hard. The argument of this is the right thing to do works with some folks, but it doesn't work with a lot. And it doesn't get you the resources. And so I actually spent most of my time not trying to figure out what to do, but building my leadership skills. I got my Audible subscription free and for like a month, and was like listening to leadership books while I was like driving to work, talking to mentors and people out there, so I could figure out when I got a chance to get at the table, or how to get at the table. How do I stay there? How do I help move the neck so the head would follow? And so that's allowed me to be the first ever person of color in our department in senior leadership in 50 years. And also the only person who was at a pretty low rank. And so ranks, we go assistant professor, associate, and full professor. And I'm assistant professor. I became this at like 2 years. The next person younger, the next person on the group is at least 15 years more senior to me. And so that comes with some opportunities, but also some challenges, right? So we had some momentum, then COVID happened. You're like, oh my gosh, COVID, mother trucker, COVID. Okay. But COVID, we try to take it as an opportunity. It made health disparities impossible not to see. People weren't like, oh, I don't believe in health disparities. Like that, there's no one in their right mind could say that. People could say, have different reasons for them, but it was obvious to folks that these disparities existed. Also, healthcare was talking about Black Lives Matter is not this fringe thing, but something that we all should be involved in, and systemic racism was becoming part of the everyday conversation and what our role was. And then a lot of our departments and the finances of healthcare were struggling. Our system is created in which we make money by doing things to people, the fee for service, right? And so if people are not being seen or getting procedures or other things like that, they weren't making money. And so that was a big challenge, in addition to the other side of things where we had patients who were not getting care that they needed and then showing up really late in horrible states that we could have prevented if they would have reached out to us. And seeing the big disparities of like in UC Health, where the majority of the patients with COVID in the ICU or just admitted in general were people that didn't speak English and people of color. How we were failing those individuals in our community, the backbones of our community. And so because we had done some work already, we were able to take some advantage. So we tried to help. We tried to have some responses. I think you've all seen those tepid responses and you're like, what is Ben and Jerry's talking about for systemic racism? But we tried to have statements and try to actually have follow-ups with that. We formed a book club. One of our faculty decided that they were going to, let's look into this. And so they read How to Be an Anti-Racist and then other sort of books on racism. And now we're doing work on disability. And we formed some new committees and looking at things that we knew that were issues, mentoring and supporting folks, issues of gender. How do we help with the pipeline? And I started seeing a change. As opposed to being the person in the meeting that always spoke up about these things, other people were speaking up. And they were using the right language and saying the right things. I was like, oh, this is nice. And so the culture was slowly changing. And so I think that's exciting to know that we're slowly getting to a group that I feel we still have a long ways to go in fighting really, really challenging structures, but I'm really proud of my colleagues. And then we also looked at strategic partnerships. And so that's where I'll talk a little bit about sort of how our nursing sort of came up. Beginning of the pandemic, right? Everyone's freaking out. We're all making up stuff. Suddenly everyone's doing telehealth, trying to do social distancing. Hot mess. they don't know what to do with students. They're like, sorry, students, love you, but bye. We can't have you get COVID. That's going to be a politically nightmare. So everything's virtual. Deal with it. And so we're in this situation, and you students are amazing. You all want to help. You know, there's a gap in some of the things you can do as students, but there's also, you have a lot of assets and knowledge. And so student projects came up and people went together and organized these sort of things. And we found this opportunity partnering with the nursing school, saying, we know that our patients of color are disproportionately being affected. We know that our geriatric patients are disproportionately affected. We know that folks with chronic disease are disproportionately affected. Here's the list of people that meet those categories. Can you call them? And so, and with the help of one of our nurse care managers, organized a group of 1 to 2 students a block, in which called our patients, did a screening for social determinants of health for them because we'd already had that workflow in place, asked them depression questions, asked them how they felt about managing their diabetes and they felt like they could do that. Talked about loneliness, just saw how they were. If they found something out, unlike lay patient navigators, nurses know stuff. So could do some counseling, connected them sometimes to our nurses or social work, or let the provider know, say, hey, this person would like to be seen. We saw this. It was huge and powerful and helped give a light. And honestly, it's been one of our most successful partnerships we've done with groups. And I think that shows that sort of team approach of thinking creatively and coming together to do things. There's some other cool things we're doing in our clinic and have been doing for a while. And I can talk about them if that's what you all want. But I'm going to go to just my last slide for now. And the other slides are hidden, and I have them ready if that's where this conversation goes. But I think it's important to think about, what are your passions and who else is passionate about it? Understand the system and the role in the system you play or in perpetuating these inequities, and how can we make differences? How can we take a systems approach to solving problems? Do the things that are important, and those are like the P's: policies, practices, procedures, right? We didn't have to create opportunities with the pandemic because there's this thing in change management called the burning platform. It's like saying, hey, everyone look at this, we need to do it. We didn't have to create urgency, it was already there. So being ready to take advantage of that, and then when people stop caring, because people will eventually always stop caring, how do you then create that burning platform again and say, hey, no, this has to be different. This has to be a turning point. It can't just be a moment. Know what support you need to be successful, and how can you advocate for that successfully. The way that I worked on it was I did stuff for free for a year, made myself very visible. Everyone knew who I was and what I was doing. And I met with leadership and said, I'm busy now. You're going to pay me to do this, I'm going to stop. I'm going to make sure people know why I stopped. They're like, oh no, we can't. We'll find some money. Sorry, we couldn't give you more, but here's some things. Like, thank you. And then we kept on advocating and going from there, asking for what we want. But we were very, very strategic, and I'd be working on folks like 6 months in advance, subtle comments, other things like that, so that when the time came for my ask, I tried to make it so that the answer was going to be yes. How are you going to be creative and do the next right thing? I love the Olaf quote from Frozen: when the future is uncertain, all you can do is the next right thing. And I think just thinking about that. And then I think it's really important to be mission driven as people in healthcare, no matter what field you're in. Have that North Star of how you decide what you're going to do, what you're not going to do. But then also know that you have to be flexible. You don't want to be flexible enough that you deviate from that North Star, but know that you might need to do things a little bit differently, as COVID made us do things very differently. With that, I'm going to stop and look at the chat real quick. Great. So I just want to open it up to you all for questions. What's on your mind? What do you want to talk about?
Since I was part of the nursing school partnership, I'm curious to know how and why that partnership became so successful so quickly. I think you're saying it just started last year in COVID times, right? So first of all, kind of, yeah, how did it come about, and how do we keep the momentum and make it more successful?
Yeah. Part of what made it come out was we weren't having to start everything from scratch. And so we had been doing social determinants of health screening in our clinics for a couple of years because someone else had started that. So we just kind of took that screener and turned that into a script. The main leader of that group, our nurse care manager, had something in place for patient navigators who are lay folks, but there's always these issues of their scope of what they can and can't do. They're also older and they're very bad at computers. And so having them go to virtual for Epic was just nearly impossible. Uh, and I think there was a good group of people that just like really cared. We also had systems in place of like how to call and so forth. So I think the fact that there's that knowledge, there's that time, some systems in place that made it helpful. One of the things I think we're struggling with is going to be our main nurse champion is retiring. No one else has time right now, so we're trying to work creatively to figure out how can we get the processes and the extra work that she done and get that down so it's, as opposed to 20 hours when she first started, she's gotten that down to like 4 now that there's more systems in place. But what can we do so that it's easier to have someone else help supervise it? How can we advocate to our system to pay for it? How can we look creatively of sustaining it? Because it'd be great if we could do this on different conditions other than diabetes and do it for other clinics, because I think one of the things that students have really enjoyed has been it's one of the few opportunities they have to work in an outpatient setting and see what ambulatory care is. So it ended up being sort of a win-win situation.
Could you kind of explain? I didn't do that AFW Williams rotation, so I'm just curious. It sounds like you guys were calling patients and asking social determinants of health related questions, and then I'm curious what you do with that information and kind of like how that fits into the greater like UC Health scheme of things, I guess.
Yeah, so social determinants of health is one of the many questions asked. I think it depended on what people said. If they screened positive for social determinants of health, we could then connect them with our social worker or care manager, or if something's a little bit more streamlined, just give them the resources at that time. We found out someone wasn't doing well or get them set up so they can be scheduled to be seen in the office. Because if you think about sort of our goal should be population health and how do we care for people outside of our walls, we do such a bad job at that. So it gave some opportunities there. If they're having issues with their diabetes, then we could get them and be seen, but we also have some pharmacists in our clinic who could call and help those patients. So it's more of this identifying a situation. We've also added some COVID vaccine questions to the process too, just to have that conversation started with folks, because we know there's some hesitancy in certain communities, and we want to make sure that they're getting some accurate information, or that we can point them in the direction to get accurate information from someone that they have a relationship and trust. What else? I'm just reading these comments in the chat in the meantime.
I love book clubs, so I'm curious what your next book club book is.
Yeah. So we realized that though people love book clubs, it can be challenging for some folks. And so what we've done is it's more like a media club. And so usually it is a book for one sort of session, then it's a movie or podcast for the next. And so we are doing disability rights right now and watched Crip Camp on Netflix. And so that is what we've done there. And then we'll plan on doing some podcasts and a book for some of the future sessions. We started off with How to Be an Anti-Racist, which was pretty dense. And then also did the book Cast as well. Those were two of our big books, but then had Seeing White podcast, which I enjoy, and just kind of talking about sort of the history behind whiteness in the United States. Those are a few of the things that have happened over the past year. So I'd love to know, what do you all struggle with? What sort of the work you do with this group or hope to do with this group or after this group? Some of you are graduating in 16 days. Exciting.
I guess for me, like something that I think about a lot is just going into, I'm trying to get a job because I'm I'm one of the folks who's about to graduate, trying to get a job in inpatient care. And I feel like a lot of times working like as a nurse in a hospital can feel like you're treating like a festering wound. Like you're seeing someone at the very end of their illness a lot of times. And like, I feel like a lot of times it feels really hopeless because we really aren't doing a lot to address social determinants of health. And like the reason that people, like so many people are sick with diabetes and are at like end stages of diabetes and are losing limbs and stuff like that. I don't know if you have any advice for like how to address social determinants of health in our day-to-day work as nurses in inpatient care, or if that's like really just something you have to do as a system in general. That's what I struggle with.
Yeah, that's a great question. I think it was a yes and approach. So day to day, you have that interpersonal, right? You're also noticing that you're seeing the festering wounds on folks that come from certain backgrounds. How can you look at how can you make sure that you prioritize doing implicit bias or encouraging your colleagues to do implicit bias so that every interaction this person has with the healthcare system, maybe it's better than the interactions they've had in the past. And they see some of that trust. Maybe you take that extra time to go over those discharge instructions because someone else will just hand it to someone even though they might not understand it. I think there's also opportunities for what you advocate for, like, when you have group meetings and other people are above you and they're like, what do you want to learn about and so forth, you can say, hey, I'd like to learn more about this sort of issue, or I'm seeing this. I think also in healthcare we have this ability where we're seeing these intimate parts of people's lives and stories, and we can take those stories and elevate them to folks that have some ability to make change. And so whether that's at your hospital system or working with other nurses or interdisciplinary sort of groups and saying, hey, we should make a policy change for this because I see this happen with patients, and let me tell you a story. And at the state capitol, facts don't matter nearly as much as an actual good story. And so you being able to tell that story to a patient, people are like, oh, and that leads to change. The reason we don't have motorcycles helmet requirements in Colorado are because of a lot of stories of folks of wind in their hair and so forth that we know from a public health perspective, horrible, right? But every other year that goes up, it just gets defeated, right? And so opportunities there. The other thing I would say with that is you'll start noticing some patterns like, it'd be easier if we just had this for right here. Or you say, you realize this is actually a wonderful phrase. Do you think we could send this to the literacy team to get it translated in X language and we can just share it with everyone? Those little things are incremental, but they do make a difference for folks. And I think the challenge with our jobs is we will make a difference in so many people that we don't realize we make a difference for. And we'll also do harm, either in, it might be not physical harm, but even just a little comment that we say that we also don't realize. And so I think those incremental things can add up and make a difference. Great question. Keep them coming. This is time with you all. I love to hear your voices.
I work in a trauma setting, and for me, it's hard to get colleagues to acknowledge their own implicit bias in those settings, and also looking at, you know, the patient populations that we take care of. Do you have any recommendations on how to work to change that culture beyond just my own self-awareness in regards to that?
Yeah, and so I think it depends on sort of where the barriers are. Sometimes the barriers are some of your colleagues don't get it, but you might have someone who's a supervisor that might be more inclined. And I don't know what your sort of situation is. If that's the case, you can talk to them. It's like, hey, do you think at one of these meetings we could bring in this person or do some sort of training on this sort of topic? I think it might be helpful for us. Sometimes just easing people into, you know, those meetings that already exist and just slowly talking about that sort of stuff will help them get there. I think also you can think about it if you all do like any sort of morbidity and mortality conferences or M&Ms, and just when you have opportunities to speak, you can slowly incorporate it into your work, and people are like, huh, never thought about it that way, of that outcome and how that relates to this person's, where they grew up or some systems in place there. Those little things can slowly help change the culture, but culture changes hard. Any more specifics about that you wanted to bring up? Because it's hard, because sometimes I'm throwing out ideas, but it's more of like kind of your exact situation.
Yeah, I think the barriers for our team really start at the top. So our organization is trying to add those into our M&Ms, and we're kind of getting stonewalled. So I think we're now going to approach it more to add it to like our nursing area-based council and start from there. And then once we have more support from nursing staff, we can bring it back to the M&Ms. So yeah, we're trying. It's hard.
I'm curious, why do you think it's being stonewalled?
I think it's an individual's does not want to acknowledge and do their own self-digging for that. It's a complicated dynamic with that particular person. So I don't really have any other insight beyond we just keep being told no.
Kira asked in the chat, does your clinic do any form of outreach?
And so definitely going to answer that. I think one other thing I wanted to mention to Liz was thinking about sort of value alignment. And so thinking about where you and that supervisor might have some shared value or outcome that you all can agree on, whether that's patient care or a certain situation, and oftentimes starting there, you'll be able to get somewhere a little bit closer, though usually not where you want to, but you can at least get your foot in the door that way. So Kira, regarding any form of outreach, we do. So this nursing project has been part of how we've done outreach. Other ways that we've done outreach, we've had patient navigators in the past reach out to patients that have been referred to social work. We also, sometimes if we notice something with care managers, we reach out to them as well. Our big health system will reach out to folks on certain like birthdays to just say, hey, it's time for your colonoscopy or something else like that. Or if it's been over a year and they're still requesting medications that haven't been seen, they'll reach out and say, hey, it's time to do that. But I think we still struggle a lot with really building that community with our patients being part of a big system. I think there's some benefits of being part of a big system, but some of the challenges are sometimes we're limited by the bureaucracy to do certain things for outreach. Like we're not even allowed to send certain like mass messages via the online portals and other things like that. We'd have to send it snail mail and other things. And so some barriers there, which is why doing some workarounds have been okay. And so a question about vulnerable populations. We are located in the Central Park, formerly known as Stapleton region. And the nice thing about that area is we have a pretty racially diverse group of folks that end up coming to our clinic. And then we also pretty financially diverse people too. We have people who are CEOs and part of like, the university hospital and all that other sort of stuff. But then we also have people that have Medicaid and Medicare and a lot of people that are sick. We do certain care. We're one of the few clinics that does gender affirming care. We also do medical assistant treatment with Suboxone at our clinic. And so those are two groups in particular that we've been building a patient panel for. And then we also, because we're family medicine, we're one of the few family medicine clinics in the UC health system, we have a desire for pediatric visits, and we actually require a certain number for our residents that we train. And so we advertise to our pediatric patients, a lot of them will have Medicaid, and we make it so that if those parents also have Medicaid, we're not going to turn them away. And so we do have several low-income folks as well that we care for. We have some Spanish speaking and other languages, but it is a predominantly English speaking group. I'd say maybe about 85% speak English relatively well at our clinic. Yeah. Anything else from folks? And it doesn't necessarily be questions, it can be comments, it can be reflections, poorly formed thoughts. All are welcome.
I guess I kind of have just like a perspective. I've lived in Denver for 3 years now, and I came from Chicago, and I have yet to, I guess, select a primary care physician. And that, I guess, is kind of just based on being from Chicago, and they have a boys' town where it's just like a neighborhood. And I think it's kind of naive for me to think that just because an organization says that they care for all people, what that really means, or if physicians, I guess, care about people because they have to care about people. Like with Pride Month coming along, companies are going to jump on the Pride train, but it's like, do you actually care about that, or are you just looking for customers? Or as far as like Denver Health, I don't work there, but like talking about caring about gender affirming procedures, like that's like a scope, but how much does that actually matter to an individual person? It's hard for me to like connect with a primary care physician, and poorly formed thought is what you asked for, so that's what came out.
Yeah, I appreciate that, and I want to reflect what I'm hearing, and please correct me because I don't think I'm going to get it all right. So as an outsider coming in that doesn't fit the cisgendered white male group, we're part of this healthcare system that says it cares about folks that we all know. And it's been challenging to, correct me if I'm wrong, take a leap to see if people actually do care, and that has been a barrier to potentially engaging and finding even your own primary care. Is that okay?
Yeah, and I've even gone to the clinic that you're at and kind of just took a whim and just whatever, and I didn't feel like I don't have any issues pertaining to my sexual orientation to have to talk about it. Felt like I've had providers in the past that made me feel comfortable talking about it. Like there was the question of like, do you want to have STD testing? And I was just like, nah, I'm in a monogamous relationship, so I'm not worried about it. And I kind of took that as a stigma of LGBT people and promiscuity. And I didn't need to take it that way, but that's how I took it. And I didn't really know how to walk away from that interaction.
Yeah. Yeah, and I think we all have our own sort of life experiences and how we've been treated and how the system treats us as an individual and treats groups. And I think that's also one of the benefits of sort of diversity when it comes to sort of the healthcare system. The argument for diversity there is not necessarily, sometimes it's that people give better care, right? So, but there's also that comfort of finding someone that's similar to you in some sort of way, so that you have that trusted relationship where you feel like you can be your honest, true self and speak your truth. And that's definitely challenging. Appreciate you sharing that.
I just feel like I'm kind of relating it to like sometimes the distrust of Black people with the healthcare system, and trying to figure out how to make somebody believe that you care beyond words is a hard thing to do.
Yeah, words don't really matter that much, right? It's experiences, what they see over time. When I see people stepping up and speaking up, that's when I trust them. I also tell folks oftentimes we need a couple of times. The big thing I tell my patients when they want to see, when they're slowly considering seeing someone for behavioral health, is like, give it 2 or 3 times. You have to give it 2 or 3 times. You give it just one time, you're going to hate that person. Remember, you're both trying to feel each other out. But if after that time you still don't feel it's a good fit, you deserve a better fit. Pick someone else, but give it a shot, please. Anything else?
Hi, Dr. Piggott. Thank you for being here. I really appreciate that. And I would just piggyback to what Jeff just said. For example, let's say when you go to the clinic and then the provider is asking, is telling you that maybe you should do a STD panel. I think it's also depend how the question is asked to you, because sometimes the patient was like, okay, why are you asking me that? Why are you telling me this? But I have noticed that if there's some questions that are some procedures that are standard. So let's say, like, for example, the STDs. So if the provider would have presented the question to you in a different way, for example, maybe saying, okay, every year it's recommended that, everyone age this to this age to do a STD panel, for example. Or maybe ask first, okay, are you in a monogamous relationship, to assess the risk of, STDs before offering, the testing. So I think it overall is depend like how the provider actually approach the patient, to make them comfortable and make it not personal, because sometimes the patient would think that, okay, you're asking me this because maybe you think, it's because of my sexual orientation that you're asking me this question or you're offering me this test. When sometimes, it's honestly a standard of care, and then it depends how the provider will approach that. Being a person of color, it does have some advantages and disadvantages. Can you tell us a little more about that? Like, in the clinical setting, like, as you encounter patients from different backgrounds, what advantages, and disadvantages have you seen in practice? That's my first question. And my last question is, now, with policies and Medicaid and Medicare, we have like really limited time to spend with our patients. And those sometimes they come to the clinic with so many issues and they want everything to be resolved in that one encounter. How do you address that due to, time restriction that providers usually have? Thank you.
Yeah, and then getting to what you were alluding to earlier on, I think it's sort of Gabby's point of sort of how we can make a difference is in part our communication. I tell folks what I regret is not usually my clinical decision making. Even if there's a bad outcome, there's a reasonable choice and there's no way for me to know. I do regret sometimes the way I've communicated to patients, colleagues, etc. And so that's something I always actively work on. Benefits and disadvantages. I think I'm one of the few primary care Black male doctors I know in the Denver metro area. Patients literally go near and far to find me. And so the honor that it is that someone really wanted that concordance and be able to provide that for patients is really special. Now that I've started doing some gender affirming care, there's not a lot of places that do that. And so it's someone that drove all the way from Pueblo, because we were the closest location. Like, that's ridiculous, right? So that they can get hormone therapy. And so much privilege there. Just in general, there's just disadvantages are that there's certain things that come up that are related to your identity that you wish you had a safe space to talk about. And sometimes you don't feel safe talking about that with friends, colleagues, a provider. And so that's one of the challenges. And then also it's hard to not take things when you see people that have some of your identities suffering and not take that in part personally. And so having that extra burden, I think, is challenging. And the second question, what was that again?
Sorry, the second question was related about like the time limitation, time restriction that providers have in clinic, and then patients showing up after a year or sometimes over a year, and then want everything to be addressed in that visit. So they have, all kinds of things going on, and then they want it to be addressed now.
Yeah.
How do you manage, this type of situations?
Yeah, I think there's different models and systems that allow you to do that well. Direct primary care, I think, is great in that it allows people to really truly spend the time. But the reality is most people don't have that sort of setting. And so I refuse to practice in a place where there's that 15-minute visit, but I have 20-minute visits, and then for some patients, 40. But that's usually if I know in advance and gets lucky. And so we talk about sort of communication and agenda setting, making sure we're addressing what's most important to that patient. Building from there, and I think one of the benefits of outpatient primary care is you will see this person hopefully again, right? They have a lot going on. You do need to bring them back to talk to them about it, and how can you use your team and systems to do certain things. Like, we have systems in place for our staff and so forth. We'll ask certain questions and do that so that I don't have to spend my time doing those tasks, and I can just focus on whatever the patient wants to actually talk about and address. And then if they have lots going on, then I can advocate like, hey, let's get this person a 40-minute visit next time so they can do all this sort of stuff. And a lot of the things that people want to talk about have been there for a long period of time, so we need some time to figure it out anyway. So the tincture of time is a benefit in primary care that can be helpful. think we're at time. Is there anything burning from folks? I wish you all well. Know that this is a journey. We will all screw up, and I screw up all the time. The goal is just always be a little bit better, and think about this as much as you can from a systems perspective, because that'll have the biggest difference.
Thank you, Dr. Piggott, for speaking with us today. It's been a great conversation. Thank you, everyone, for joining us.